both Dr. Yaffe and Dr. Salmon have shown us some of the underlying pathology and alluded to biomarkers and the roles that they may play. So I'm going to go into this in a little more depth. A couple of disclosures which are unrelated to any of the material that I'm going to be presenting. So let's come up with some basic definitions. What is a biomarker and why do we think we like them? So biomarkers are quantitative or numerical measures that are related to a disease process. And so if one thinks very broadly, biomarkers can perform all kinds of tasks. So in diagnosis, one can think of measuring cholesterol, where certain types of cholesterol levels are an index of somebody's risk of heart disease. There's an absolute level of cholesterol. There are suggestions of different cutoffs, and there are targeted therapies based on measuring cholesterol. So it serves a number of purposes in diagnosis and also then for monitoring some effects of therapy. If somebody comes to an emergency room in the throes of severe chest pain, one can measure blood levels of troponin, and these would be biomarkers of whether they're having an acute heart attack or are having indigestion, for example. Regarding treatment, probably the field that has benefited the most from biomarkers is cancer research, where people are able to study tumor burden using X-rays, MRI, or PET scanning to detect the cancer and see how it's responding to treatment. So these are some examples of the big wide world of biomarkers. Biomarkers have all sorts of different characteristics, and ideally we would like them to be quantitative, accurate, reliable. We'd like them to be quite sensitive indices of either structure or pathology, depending on what we're trying to measure. Ideally, we'd like them to be inexpensive, but the cost is going to vary with regards to the nature of the question that we're trying to answer. And so there's, I think the best way to think of how much biomarkers cost is what is the benefit of using the biomarker and what is the readout that we are going to get from the biomarker, and then we should figure out how much we're willing to pay for it. Ideally, they should be convenient and non-invasive, but there are some caveats in this regard as well, and I will cover those in a moment. So the brain is different from certain other organs with regards to biomarkers, and it's also the same in certain respects. The difference is that the brain is difficult to access, and it also consists of a number of very different regions and a mixture of cell types. The liver, for example, is much easier to access. We can biopsy it, and it has a much less interesting or diverse number of cell types by comparison. So because of all of these exciting and diverse things that the brain consists of, it actually gives us some challenges if we're trying to come up with biomarkers that we think are actually measuring some particular aspects of the brain. So the kinds of things that have been developed are imaging, for example, MRI to look at brain structure and connections, PET scanning to look at brain metabolism and chemistry, or cerebrospinal fluid that bathes the brain and in some ways reflects brain biochemistry. We'd like to be able to do blood testing as well to obtain some information about the brain. There's been a lot of interest in Alzheimer's, but to date there are no robust blood biomarkers for Alzheimer's. There are some preliminary ones, and there's some ones that give us some signal, but nothing as robust as these biomarkers that more directly access brain structure and function. So how would we imagine using biomarkers in the setting of Alzheimer's disease? One use would be for diagnosis. And we've heard that, especially in older folks, if somebody has cognitive changes, they might have an Alzheimer process underlying the cognitive changes, but they might not. And so the hallmark pathologies of plaques and tangles, or some hallmark distribution of pathology, could help us to be more confident about the diagnosis. And this is particularly of interest with regards to early diagnosis. we know from many, many studies that the hallmark pathology of Alzheimer's is present in people with mild symptoms, and it's even present years before symptoms begin. So to achieve very early diagnosis, biomarkers can assist a clinical evaluation. And in people where we're trying to do clinical trials, the best way to select people for clinical trials that are targeting Alzheimer's pathology is to try and make sure that they do have Alzheimer's pathology by studying Alzheimer-related biomarkers. We can use biomarkers to help us with prognosis. Once somebody does have a memory problem, the rate at which this changes over time is highly variable, and there's a lot of interest in trying to figure out if we can stratify or understand that progression by examining biomarkers. And then we can apply a number of these things beyond very general uses to very specific use in treatment studies. So one big question is target engagement, which unfortunately has been overlooked in many of the Alzheimer trials done to date. And the basic question is, does the study drug affect the mechanism or pathway that it is supposed to? The second question is, how much does it affect that pathway? But the basic question of target engagement is critical for drug development and for clinical trial interpretation. And then thinking more holistically, assuming the treatment makes sense, does engage its target, how does this actually affect the brain? So with regards to target engagement, it is very, very important to try and make sure that if we're giving somebody a drug that we think is influencing a pathology, that it actually gets there and makes a splat on the pathology, and biomarkers can help us. So what do we know about Alzheimer brain pathology? So as you've heard so far, we know two big things. One of the big things is that there are plaques, these sorts of structures over here, and they're made of amyloid beta protein, or A-beta. We also know that there are tangles, and plaques occur outside of neurons, tangles occur inside neurons, and they are very appropriately named. But that's only scratching the surface. There's a lot of other stuff going on. So these are inflammatory cells. This would be an astrocyte and a microglial cell, and they are involved in the response to Alzheimer pathology in quite complicated ways, and they may have protective and deleterious aspects of their function, and it may be necessary in terms of understanding Alzheimer's to be able to actually measure what these cell types are doing. This would be a blood vessel. There are many blood vessels coursing through the brain and near plaques, and blood vessels can be affected as a consequence of amyloid. Blood vessels actually help the brain under normal circumstances to get rid of amyloid. And so trying to assess a number of different players in this picture would be the most overarching way of using biomarkers. At present, we're best able to think about plaques, tangles, and then some other overall general aspects. So again, this is going to be yet another version of the sort of slide that we've seen before, but I think that repeating how these concepts have evolved is very, very important. So if we think of cognition and function as being a continuum with some declines during normal brain aging and a much greater decline occurring during a transition from MCI to dementia, there's a sort of imaginary line that represents the barrier between MCI and dementia that we sort of know when people cross, but we can't quite measure exactly clinically. And so there's pathology underlying all of this happening. We believe that plaques build up during the period of normal cognition and MCI, and we think that the plaque burden tends to reach a maximum by the time someone reaches a stage of dementia. And plaques don't change, at least according to the ways that we measure them. There may be some subtle ways we don't yet know how to measure, but plaques don't change that much once somebody has progressive dementia. Tangles may begin early, and tangles do progress throughout the course of dementia, and the tangle burden and their distribution does correlate with the extent of cognitive progression. Vascular disease is the other component, and even in people who have Alzheimer's, especially late-life Alzheimer's, we think that there are contributions and interactions with vascular disease, and that these would be things to think about throughout the course of dementia. So these would be examples of the kinds of brain pathology that lie beneath the surface that we would like to index. And as we've heard, we also are very interested in the context of prevention, where people who may have some burden of pathology could be distinguished from people who have a low or negligible burden of pathology, and we might come up with this term of preclinical Alzheimer's disease during these stages and try to enroll such people in a prevention trial. So how do we relate and map back the biomarkers that we use to the kinds of pathological changes that we observe in brains of people with Alzheimer's? So this is a brain of somebody with severe Alzheimer's disease compared to the brain of somebody who had intact cognition. It's pretty obvious what the differences are. If we're going to measure these sorts of differences earlier on and during life, we would like to index brain structure, and we can index atrophy or shrinkage of brain areas by doing very careful quantitative MRIs. We can look at brain function. The brain uses glucose more than any other organ in the body, and so we can do a FDG, which is a radio-labeled glucose PET scan, and see which regions of the brain are using glucose a lot and which regions are not using it that much. Can we monitor the underlying pathology or the biochemistry at the very least? So CSF allows us to measure a number of the players that are involved in these pathologies. We can measure A beta 42, which is a form of the amyloid beta protein that deposits relatively selectively in plaques, and it is decreased in CSF. We can measure tau and phospho-tau, which are related to tangles, and they get into CSF and are increased in Alzheimer's disease. We can do amyloid PET imaging, and very recently the ability to do tau PET imaging has been developed and is a very exciting addition to the biomarker arsenal. So we'd like to be able to look at biomarkers and build a timeline if we're going to imagine doing targeted prevention trials that maybe are focused on a particular kind of pathology. And so far, a number of large-scale studies have collected very detailed information on people who start out at different levels of either normal or mildly impaired cognition and then are followed over time, and biomarkers are collected in depth. Three such efforts are the Alzheimer's Disease Neuroimaging Initiative, or ADNI, the Australian Imaging Biomarkers and Lifestyle Study, called ABLE for short, and then the Dominantly Inherited Alzheimer Network, or DIAN, and Dr. Andy Bateman will tell us a lot about DIAN tomorrow. This is information that is similar to a slide that Dr. Yaffe showed earlier. This is data that came from the DIAN study. So these are a number of people who have genes that are altered that puts them at risk of developing very young onset Alzheimer's, with typical onset somewhere between the age of about 30 and 50. And if one takes a look at changes, among the earliest changes are a decline in CSF beta 42, an increase in amyloid deposition, which can be measured by amyloid imaging, an increase in CSF tau, and these are all happening. This would be the estimated year based on the typical year or age at which that family begins to develop clinical symptoms of Alzheimer's. And so a lot of these changes are evidenced 10 to 20 years before the predicted familial expected symptom onset. This was the initial attempt at putting this data together, and the model will be refined as we collect more data. But the bottom line is that there are early changes that are happening while people still have preservation of cognition, and this is an extremely valuable study to then try and figure out how interventions might work, especially if they're begun early. So this is a variation on the slide that Dr. Yaffe showed you earlier, where, again, we think that amyloid biomarkers probably lead the way. Tau biomarkers, CSF tau may follow soon after. With the advent of being able to do tau imaging, we may have to rewrite some of these curves a little as we figure out when tau deposits form in the brain, because CSF tau is a very indirect measure of tau pathology. MRI changes, depending on how they're measured, we think begin a few years later, but again, there are advances in MRI technology, and it may well be that there are subtle changes in brain function or connectivity that may be mapped back a little earlier. By looking at how much change people have in any of these areas, we might decide that they've had relatively little change, and this could be compatible with the range of normal brain changes accompanying aging. If they have intermediate change, they may be at a risk for having mild cognitive impairment, and with more extensive abnormalities, they're going to be on a trajectory for dementia. So these biomarkers are helping us to build a picture of what might be going on beneath the surface. We shouldn't ignore vascular problems and the vascular contribution to dementia. There are vascular biomarkers, the major one of which is MRI imaging. And we know that vascular risk factors such as hypertension and diabetes are associated with predominantly this change of white matter hypertensities. There also are risks of developing small or large strokes, and there also are risks of developing microbleeds. But the big change that is associated with vascular risk on MRI are these sorts of white matter changes. They've been studied for many years. We're not entirely sure why people develop them. The leading theory is that there are there's borderline ischemia, not quite enough blood or oxygen delivery to cells that are critical for maintaining myelin and the myelin sheaths in these very long projections of neurons, but that's about the closest that people have gotten to really understanding the connection. Other types of vascular changes have occurred, unfortunately, in clinical trials of antibodies for Alzheimer's disease, and these have included microbleeds and inflammation. And so sometimes the therapy actually stirs up some blood vessel changes. And so using MRI in the context of prevention trials is an important aspect of trying to monitor not only what might be going on in the brain structurally, but also safety and potential drug-related effects. Using MRI, we can track changes in brain volume over time, and so there are very sophisticated computerized methods for standardizing how a brain map is constructed from an MRI, and this would be an example of a baseline map in which areas of cortex, subcortical structures, this would be the hippocampus, are identified, and their areas and volumes can be measured. Different areas of cortex can be segmented. And then if one looks at change over time, this would be change over 1 year. In a group of patients, this would be change over 2 years. And red are areas that are getting bigger, so fluid spaces such as the ventricles get bigger. Blue are areas that are getting smaller, so areas of cortex get smaller. And so we can get a very good idea of changes in brain structure over time as part of the natural history of both aging and the evolution of Alzheimer's and other forms of dementia. So Dr. Yaffe showed this slide as well a little earlier, which emphasizes the gap between what we know from pathology studies, the time course of when amyloid plaques show up at autopsy, versus in different studies, the risk of developing the dementia stage of Alzheimer's disease, which again suggests that there is a window of opportunity when people don't yet have severe cognitive loss to try to either remove plaques or to address toxic forms of amyloid if we believe that amyloid is the critical trigger, or perhaps to put a brake on other processes that actually lead to the clinical expression of the symptoms of Alzheimer's disease. It turns out from studies that some people are able to put up with a fairly substantial plaque burden as they age and die, and understanding resistance to plaques and susceptibility to plaques is a very important part of the way forward and an important part of trying to develop therapeutics. So this is what brain amyloid imaging can tell us. Amyloid PET scans are able to detect amyloid deposits or plaques in the brain, and we know that they become positive at least 10 years before people develop symptoms. So these are examples of an amyloid scan from somebody who has Alzheimer's disease, where they have a lot of amyloid deposition in a number of different brain regions. This would be someone who has MCI with a moderate burden, MCI with a severe burden of amyloid, MCI without amyloid, suggesting that whatever's driving MCI in this particular individual is not amyloid and possibly not Alzheimer's disease. This would be a control who has no amyloid. This would be a control who has some amyloid. Control meaning somebody with normal cognition. As more and more studies have been done, we now know that about 30% of people over the age of 70 have amyloid-positive scans. How do we interpret that? So firstly, we need to know, is there a relationship between how much amyloid we're seeing on a scan and how much amyloid pathology we're seeing at autopsy? And so a couple of studies have been done. This was the first during which people were imaged using amyloid imaging. These studies were done in people who were at advanced stages of dementia or who were receiving hospice care and who very magnanimously and generously agreed to donate their brains for scientific research after death. So the pathology was examined typically within 6 months to a year after when the scan was done. And the bottom line is there's a strong correlation between amyloid burden on PET and amyloid burden at autopsy. And if one used certain cutoffs on this imaging, the first time it was done, a particular cutoff could identify 93% of people with autopsy-diagnosed Alzheimer's. As we've gone into less selective studies, it becomes much harder to say that there is a definite cutoff in a definite way to be able to use the scan to diagnose Alzheimer's disease. It can certainly identify an amyloid burden and the presence of amyloid in the brain. So now that we're able to use amyloid imaging as a tool, what happens if we take it into research studies? A number of different groups have done this. The Australian, the ABLE study, is the one that probably has the most data at this point. And they started out by imaging 160 people, cognitively normal, when they were enrolled, with a mean age of 72. During the next 3 years, some of these folks progressed to develop a clinical diagnosis of MCI or Alzheimer's disease. If they were amyloid negative, they still could progress, but a relatively low number, about 7%. If they were amyloid positive, on the other hand, in their study, it was about 28% of people who are amyloid positive showed progression. It's a little unusual. These are very high progression rates, in fact, a little higher than one might have expected in the general population. And some of us have wondered if there was a little bit of a selection bias within this cohort, but it's an excellent starting point to at least show the difference between amyloid positivity and amyloid negative. And in some of these people, if you dived a little deeper into memory score performance, people who are amyloid positive and had a little bit of below average performance, still in the normal range, a little below average on a sensitive memory test, had the strongest risk of progressing over this 3-year period. This shows how much variability there is in amyloid scan burden. So in people with Alzheimer's disease, this would be one of the widely used cutoff points. This would be a different cutoff point. Almost everyone who has a really solid diagnosis of Alzheimer's in this particular study had a significant amyloid burden. People with MCI were mixed. A lot had amyloid, but a lot didn't. And among people who were cognitively normal, many do not have amyloid, but some do, and these folks may be the ones who are showing a higher risk over time. Similar findings have come from studies by other groups, Mayo Clinic and Mass General Hospital. How does amyloid imaging itself change? The answer is not by a whole lot. So these are, again, from the Australian study, people who are imaged baseline 20 and 40 months, and you can see that there's not a very robust or marked increase in total amyloid burden. And so what we're measuring may not be the direct cause of cognitive change. However, if one tries to model what is beginning and when changes are happening, in their study, their model suggested that amyloid deposition was happening way in advance of other changes like hippocampal volume or cognition and so forth. So if one took a hard endpoint of a confident clinical diagnosis of dementia. In their study, the amyloid threshold would have occurred about 15 years earlier, and some of the structural and cognitive changes would have occurred only 5 years before the onset of dementia. Again, this is a model. There are different degrees of confidence, and as we get more data out of different studies, we'll be able to refine this type of model. I wanted to talk briefly about tau imaging, which is a very exciting development. The first tau imaging compounds were developed by 2 Japanese groups and are now being licensed by a number of different companies. And they're useful for PET imaging of abnormal forms of tau in the brain. This was the first publication that showed successful tau imaging. So again, for a PET study, the patient receives an intravenous injection of the radio-labeled tracer, a brain scan is taken. There's a certain amount of background noise or activity which is non-specific, which one can see in these controls. Here's somebody with Alzheimer's with a mini-mental score of 22, mini-mental score of 20, mini-mental score of 17. And so here one can see that the Alzheimer patients are showing a fair amount of tau positivity over cortical areas in the temporal parietal cortex, a bit of cingulate, and also in some aspects of the medial temporal lobe, which is where one would expect tau to be present pathologically. This is an example from a study done by investigators at Mass General. This is a 70-year-old man who has very mild memory loss, and that's the tau scan. So again, it looks like there's an impressive amount of tau pathology, and yet there's only very mild memory loss. So there may be a lot that we don't understand about the exact relationship between how much pathology is building up. This would be a stage 3 staging system representation of where tau pathology would be localized. So the MRI is giving us a reasonable, the PET scan is giving us a reasonable correspondence, although it seems to be showing up more than one would expect compared to pathology over here. And this is somebody who has a disorder called corticobasal syndrome, which is a disorder that's driven by a different form of tau pathology without amyloid being involved at all. And this person is showing on a tau scan some light up in subcortical regions over here and here that are consistent with where some of the pathology of corticobasal would be found, but on PIB imaging, which is an amyloid scan, completely negative. So again, these are very, very valuable research tools to tell us something about pathology. At some point, they may have some kind of clinical application, but thinking about whether one would have to do an MRI, an amyloid imaging study, and a tau imaging study in everyone with Alzheimer's disease would really break the bank in terms of diagnostics. And I think we would need to have spectacular therapeutics before we could even go that far. CSF biomarkers assess amyloid and tau. The classic signature in Alzheimer's disease is a low level of A-beta 42, which is consistent with amyloid aggregation in the brain, and an increase in levels of total tau and phospho-tau, and these are markers of neurodegeneration. And the commercial lab, there's one commercial lab in the US that does this test. This is the kind of display and readout that one gets. CSF amyloid and tau biomarkers do precede memory decline. This is a longitudinal study done by investigators at Washington University. People who had normal CSF biomarkers it's a survival study, and so this is the risk of progressing to significant cognitive decline. So if you had normal biomarkers shown in the purple, there's a very low risk, and then different stages of the preclinical classification of Alzheimer's, so A-beta pathology alone, some A-beta and tau pathology, A-beta and tau pathology with borderline memory performance, and then with significant memory decline, allow people to perhaps stratify the downstream risk. One can combine biomarkers. This is a study that combined CSF biomarkers and structural MRI in people who had MCI. In people who had MCI with a high level of A-beta 42, suggesting that there was probably not a major Alzheimer process going on. Longitudinal changes were relatively mild in terms of brain atrophy. People, on the other hand, who had a low A beta 42 had much more marked changes in brain atrophy over time. So in summary, biomarkers provide valuable information about brain structure and pathology in Alzheimer's disease. We're able to detect changes throughout all of the stages of Alzheimer's, including during a long pre-symptomatic period. Importantly, asymptomatic people who test positive for Alzheimer biomarkers do appear to have a higher risk of Alzheimer's disease, but it is not inevitable. So being biomarker positive does not mean that somebody is absolutely on a definite course towards getting Alzheimer's, as best we can tell. There are many, many roles for biomarkers in general, but in the context of prevention trials, they can help us in many ways. First, they can help us to enroll people who are amyloid positive. They can help us to identify target engagement, particularly for anti-amyloid interventions. We can track changes in brain volume over time if we're interested in whether treatment is influencing brain atrophy, for example. And we can monitor potential adverse events on the brain which have occurred in some amyloid intervention studies. So I'll stop there, and again, perhaps we can go through the clicker-based questions. I don't know if mine are quite as easy as some of the previous ones, so we'll see if you've all been warmed up. So first. Okay, so this one was quite a bit harder, but some important concepts lie behind the answer. So I'll go through it a little. If the scan is positive, the person will almost certainly develop clinical symptoms of Alzheimer's within the next 5 years. The answer is no. A fair number of people seem to be able to tolerate amyloid positivity on scans, and we cannot make any statement about extremely high risk within 5 years of having an imaging study based on the scan alone. If the scan is negative, the person will still show benefit from participating in an anti-amyloid prevention trial. So this would depend on the design of the trial, if the trial was trying to prevent amyloid from building up at all. But if the trial is trying to remove amyloid, then enrolling someone who doesn't have amyloid deposition is not going to be helpful. If a person with a positive amyloid scan develops dementia 5 years later, the dementia is almost certainly due to Alzheimer's disease. That's actually not true. If somebody with a positive amyloid scan has a whole series of strokes, for example, they have developed vascular dementia, and the amyloid may be completely irrelevant. So again, one needs to think very carefully about what one is measuring. What one is measuring with an amyloid PET scan is number 4. About 20 to 25% of people in that age group are likely to have a positive amyloid scan. It means they probably have some amyloid deposition in their brain. Maybe that changes their risk. That's all we can say. Next question. Apologize for the amyloid, it should be amyloid. Okay, so again, the jury is divided. So this one also we asked you for which of the answers is false. So if you remember from one of the slides that I showed, if one does serial amyloid imaging, it doesn't really change a whole lot, and the slide I showed went as far out as 40 months. So over 12 months, amyloid biomarkers are barely going to budge in somebody with this particular scenario. So in fact, that is the answer that is false. Neurodegeneration is likely to have worsened markedly if someone progressed from MCI to dementia. The answer is yes. The reason that they have progressed is probably related to brain structure and to progressive atrophy. If somebody has a negative amyloid scan and yet they have MCI, their symptoms are unlikely to be caused by Alzheimer's. We think that that is true. So having a positive amyloid scan is a little bit uncertain. Having a negative amyloid scan means that if you have symptoms, we just don't think that they are caused by Alzheimer's disease. And there was an FDA adjudication and then a CMS adjudication about how to use amyloid scans if they were going to be used in the clinical arena. And the verdict was that amyloid scans should not be used to diagnose Alzheimer's. They should be used to exclude Alzheimer's. And so that's the point behind that question. A positive amyloid scan indicates Alzheimer's is the cause of the likely dementia and progression. That is probably true, although she could have had vascular dementia independent of having the amyloid scan. So the best answer of which is false is number 1. I could possibly give credit for number 4 in this scenario. But again, this illustrates some of the complexities about what we think we're measuring and how we interpret those measures. So I'd like to thank you, and we're going to have a brief question and answer session. I'd like to have the other speakers come up.
Dr. Sheldon Wolf, UCLA. Dr. Galasko, if you took 2 groups of people with equal amounts of amyloid deposition in the brain, one which was cognitively impaired, one apparently cognitively normal, but equal amounts of amyloid on the scan, what are some of the main ways that these groups would differ? Education, vascular disease, well, what?
Okay, so
what
it's
would be the differences between these groups? I.e., what do we know about constituents of what we are calling cognitive reserve?
Oops. I'm sorry. Okay, so it's a great question, and I'll rephrase it as why might some people be susceptible to a certain amyloid burden? Why might some people be resistant? So nature and nurture. Some people might have general bad health, vascular risk factors. They might be on a bunch of medications that are contributing to accelerate cognitive decline. They may have susceptibility to develop tau pathology, neurodegeneration, or other things in response to amyloid that are heightened compared to the people who are resistant. And we don't understand all of those factors, but we're trying to improve our understanding of them as time goes by. But having said that, I think there are very few diseases where one can look at a single measure and say that we can translate that measure to a very exact risk with very little variation of the readout of that risk. So somebody can have a cholesterol of 250, for example, and be perfectly happy for the next 20 years. Somebody else with the same level of cholesterol may have a heart attack the next day. So nurture is the other aspect, and some of nurture goes into brain reserve, genetic resistance to amyloid beta protein, and to plaque pathology, maybe some acquired resistance. We'd like to think that some of the effects that have been found of, for example, educational variants related to Alzheimer risk may relate to brain protection. So the answer is there isn't a single easy formula to apply, but there are all of these different factors that we need to juggle and think about. And I think this is the importance of what Dr. Yaffe was saying, that targeted therapeutics towards amyloid may be important, but I think we need to also consider holistically what is going on with aging in the brain.
Thank you.
One other thing to add about that, if you think about amyloid, if you think about it as a cascade of events that happens, it could be that what really would correlate with the cognitive and clinical changes we see are the other pathologies that are triggered by amyloid. So, for example, we know from pathology studies that amyloid doesn't correlate with cognitive deficits, but tau pathology does. So it may be that these two people are in different levels in terms of other neuropathological changes like tau or synapse loss.
So, if we assume about 50% of the risk factor for dementia later on is lifestyle choices, physical activity, hypertension, things like that. The other half, what would you name that other half? Would it be good luck or bad luck on the genes you got from your parents, or is it more than that? That's question one. Question two is low education levels. Is low education levels tied to lack of access to health care? Is that really the main message there? So those are the two quick questions.
Okay, I think this is on. I'm going to talk. I'm going to take the second question first, if that's okay. The question was having to do with education, really, and whether is it education leading to reserve, I think, or could it also be education leading to all kinds of other things having to do with poor health care or access to health care, et cetera. So I think that's an excellent question, and of course it's always hard to disentangle. I think it's probably all of those things. I am going to talk in my second talk a little bit more about the education piece and in the context of cognitive stimulation or cognitive reserve. So I think that's a very big piece of it. But of course we can't ignore that education is really often a measure, if you will, of socioeconomic status, nutrition, access to care. I mean, all of those other things. So I think your point is very well taken. It's harder to study maybe, but yes. The first question had to do with if 50% of risk can be attributable to some of these modifiable risk factors, what's the other 50%? And I think, a lot of it's genetics, I would have to say. So, pick your parents wisely.
Dr. Jaffe, what do you think is the mechanistic or pathophysiological connection between depression and dementia?
Do you mind waiting for an hour on that?
Yes.
Okay.
So I have a question. So one of the studies one of the imaging studies that you had presented was the tau PET study done by the Japanese team. The score of the person with the Alzheimer's dementia was MMSE of 17. Not many patients with that score are really going to be able to, that I know, would be able to sit in a PET scan for the amount of the study. So that brought the thought of they must have used some sort of sedation, and the question is, if in all of these studies, was there sedation used, and might that have affected the functional studies?
So it's a great question. For the amyloid imaging and the tau imaging studies, the patients were not sedated. There may have been some very careful selection. So again, those first tau studies that I've shown you are sort of proof of principle studies rather than very large-scale ones. I think they chose the most docile, compliant patients that they possibly could find. But having said that, the tau imaging study does not, it doesn't take hours of being in a PET scanner. PET scanners are less noisy and they're somewhat quicker than, in terms of imaging acquisition, than MRI scanning. So again, PET imaging, we're thinking of predominantly as a research tool. There's been a big debate about whether amyloid imaging, and there will be another debate presumably about tau imaging, should be brought into the clinical arena right now. And there's a huge debate about that. I think one of the biggest issues is unless we have really effective disease-modifying treatments, are we ready for these very, very expensive imaging tests to be trotted out?
And the ethical.
There are ethical aspects of imaging as well, which we'll hear about actually somewhat later from Dr. Karlovish. Question in the back?
Yes, can you hear me? Can you hear me?
Yes.
Yes.
All right, thank you. Since we're talking about the genetics as a main thing, what can we do is it possible using combination of aspirin, Trental, and Plavix in a population who is more than 75-year-old and putting them on a high-protein diet of something that I don't know what type of protein that will be? Will that be a good recipe for the people who are now 75 and above?
I think we'll both give a partial answer. I think that, I mean, whenever we see newspaper headlines, I think we're bombarded at least once a week by some or other study about some intervention, factor, dietary manipulation, whatever, that either cured mice that have Alzheimer's disease or had remarkable effects on people in a very small study or whatever. And there's always a cautionary note in very fine print at the end. These are preliminary findings and they need to be... So we have lots of... There's some sort of common sense things that we would probably advise, but I don't think we can come up with a definitive, absolute go-to formula for right now.
Absolutely. And I think your question was probably getting at some of the vascular etiology in particular of dementia, which is undoubtedly quite important. The drugs you mentioned in particular are more sort of, antithrombotic kind of agents or, antiplatelet aggregation, which is a really interesting question. It has more of a role presumably in stroke prevention or secondary prevention or primary prevention. But it's a really good question. I don't think we know much about that. There is an ongoing trial called the Esprit trial, which is looking at aspirin. But so I think it's an interesting area of investigation that I think we don't know much about. Could there be a combination of vascular and maybe even clotting related to cognitive deficits in the absence of a clear stroke?
Probably the same question in a different way. I mean, it's very well known, and it's highlighted today, the correlation between the vascular and the Alzheimer and the presentation of dementia, I'm sorry. And so my question to Dr. Galasko and Dr. Yaffe is that when we are treating and we are advising to control the diabetes, control the blood pressure, lifestyle changes, are we impacting the vascular element or are we really impacting the real dementia process?
Does it matter?
Yeah, excellent question, and I hope to be able to go into that a little bit more after the break, because I will touch a little bit more on some of the mechanisms behind some of these risk factors. I think it's probably both. I mean, I'd say the best data of several of the risk factors, the vascular risk factors, suggest that there's probably a vascular component, i.e. atherosclerotic component primarily, but there also may be a direct effect in terms of, say, in amyloid deposition or inflammation, et cetera.
Right, so the only... So we're thinking a little about vascular mechanisms, or we used to think about vascular mechanisms and amyloid and Alzheimer's as being separate, but there's some tantalizing new evidence that suggests that, firstly, amyloid can influence aspects of blood vessel physiology, and secondly, hypertension vascular risk factors maybe can have an effect on how amyloid is deposited and builds up. And so, again, these processes may be a little more closely related than we've thought in the past. So we'll leave you with those thoughts, and we're going to take a 15-minute coffee break. And I'd encourage people to also visit our exhibitors. We'll be back at 10:30. Thank you very much.